seen on the right here. It concerns a 72-year-old man who presented to an emergency room with abdominal pain. And here's a computer tomograph transection of his abdomen, and what we see here is massive amounts of air within the entire portal venous system. There's also free air in the abdominal cavity that we can see here and here. And we're given 5 possibilities of what this might be. Perforated ulcer might cause free abdominal air, but not air in the portal vein. And the only thing of these items that can cause air within the portal venous system is dead bowel. So the correct answer here is bowel ischemia. As shown here. And next week we'll get more information on what happened to this poor person, but I'm pretty sure this was lethal. I don't think that human beings can survive that. The first topic in the New England Journal is cervical carcinoma. This is the 4th most common malignancy in women that leading to death. And it can be either squamous cell carcinoma, as these sections on the left illustrate, or adenocarcinoma. Both are equally bad. And there are various treatments and diagnostic possibilities that are offered here. And they include irradiation. The diagnostic possibilities, the way that this disease is generally diagnosed is through the Papa-Nicolau stain. And when these stains are atypical, then appropriate biopsies are done. The condition is staged as determined by the International Federation of Gynecology and Obstetrics. And stage 1A through 1B are treated operatively by a radical hysterectomy. And this can be done as an open operation, as has been classically done for the last 50 years. It can also be done minimally invasively, also assisted by robotics. Then, depending upon the spread of the disease, the women are also treated with irradiation or chemotherapy. In Germany, the survival is dependent upon the stage in which the disease is found. And women that have stage 1 disease have a fairly favorable prognosis, so that this 5-year survival is over 90%. In more advanced disease, then the prognosis is more grim, as you can see. Now, the 2 operative procedures that are available are an open operation, and that's results in substantial morbidity and complications, as opposed to a minimally invasive approach, which is done with various trocars, and that can be assisted by robotics, as illustrated in this picture. And as you can imagine, the patients probably prefer the minimally invasive approach. And in the literature, it was claimed that both procedures lead to a similarly favorable outcome. And that hypothesis was treated in a randomized controlled trial where over 600 women with cervical cancer ranging from stage 1A to 1B were randomized to minimally invasive surgery or to the open operation. And as we can see here, the women that were randomized, ages similar, body mass index similar, the distribution of squamous cell carcinoma and adenocarcinoma was similar in both groups. The stage of disease was similar, and most of these women had 1B disease. That means it was already somewhat more invasive of blood vessels and lymphatic vessels. Their performance scores were similar, and so that the characteristics of these 2 groups was certainly comparable. The women, depending upon the severity of their disease, were also treated with chemotherapy, radiation therapy, or even both. and that distribution was also the same in both groups. Now what we see here, surprisingly, at the end of 5 years, this is the proportion of women that were disease-free, and with open surgery, disease-free survival was substantially better than compared to the minimally invasive surgical group. And this outcome was the same in terms of intention to treat analysis compared to, per protocol, what actually was done to the women. The results were the same. And here this is shown in tabular form, where disease recurrence was less in the open surgical group compared to the minimally invasive surgical group. Disease recurrence or death from any cause was also more favorable in the open surgical group. That again is shown here graphically. Overall survival was better with open surgery compared to minimally invasive surgery. Disease-specific survival, again, open surgery does better. And in terms of regional recurrence was substantially less common in the open surgical group. Now we might ask ourselves, how come? Is this somehow related to competency, or the fact that CO2 is entered into the abdominal cavity? And the answer is unknown. The removal of cancer appeared to be similar in both groups in terms of pathological evaluation of the tissue that was presented. So it's not entirely clear how this result was accrued, but it certainly seems that the women that underwent the open, more invasive procedure did better than the women that were treated with a minimally invasive operative approach. This same hypothesis was tested in a large observational study in the United States, where registry data were evaluated that were gathered by the National Cancer Database or gathered by the American College of Surgery and the American Cancer Society. And here we see the results of over 1,200 women that were treated with open surgery compared to minimally invasive surgery. And again, the characteristics of the women, large numbers of people involved here, were similar in both groups. This is not a randomized trial. This is strictly an observational study. But again, what we see at the end of 6 years, the probability of survival was better in the open surgical group compared to the minimally invasive operative group. And this result was independent of whether or not robotic assistance was provided or not. And it was also independent of whether or not this was squamous cell carcinoma or adenocarcinoma. It was even relatively independent of tumor size at the time of surgery. And again, the radical open hysterectomy group did better than the minimally invasive radical hysterectomy group, no doubt about it. And in the editorial that accompanies these two papers, the editorialist says, these results are not necessarily a death knell for minimally invasive radical hysterectomy, but the approach has been dealt a great blow. And again, the editorialist could only speculate on how this result was accrued, but it seems better that the open operation is, it seems certain that the open operation is better on the basis of these two studies. The next topic in the New England Journal is the immune reconstitution inflammatory syndrome. Clinically, this condition looks somewhat like graft versus host disease, and it concerns mostly AIDS patients whose immunology is restored once the spread of the HIV virus is inhibited by various drugs. Then the body reacts to whatever other invasions are present with a hyperimmune response that results in a clinical syndrome that is abbreviated as IRIS. And iris is common in AIDS patients that concomitantly have tuberculosis. And in Africa, this is a frequent occurrence. And the idea here is, how can we prevent this paradoxical tuberculosis-associated iris? And what clinicians generally do is treat their patients with prednisone in a certain dosage that's sort of empirical, in the hope that this immunosuppression through steroid administration will avoid the occurrence of the tuberculosis-associated immune reconstitution inflammatory syndrome, or at least ameliorate the condition. So this is a randomized controlled trial. The patients either received placebo or they got prednisone 40 milligrams a day for 14 days, and then 20 milligrams a day for 14 additional days. This is a fairly high dose of prednisone, and the reason for this is because if patients are concomitantly treated with rifampin, they metabolize prednisone more quickly, necessitating a fairly large dose. And since rifampin is a cornerstone in anti-tuberculous treatment, that's why this particular steroid dose was selected. And what we can see here is the administration of prednisone inhibited the development of iris, TB-associated iris, by about 25%. And that's a substantial difference. Furthermore, if iris did occur, it was a milder form of iris than occurred in the placebo group. And this result was similar in patients that had CD4 counts of either less than 50 cells or more than 50 cells, implying that the degree of immunosuppression caused by the disease, reconstituting that, resulted in a similar risk of iris that could be ameliorated by the administration of prednisone. The clinical adverse events were also reduced by the administration of prednisone, particularly grade 3 clinically adverse events. So this was a favorable result. So that we conclude that the prophylactic prednisone treatment here reduces the risk of iris, and if iris occurs, it's ameliorated to a significant degree. The next topic in the New England Journal concerns the treatment of breast cancer. And women with breast cancer, of course, are treated operatively, and if they have estrogen receptor expression, they get tamoxifen and they get chemotherapy if there's any lymphatic invasion, etc. But women with advanced breast cancer, the question is, what can we offer them further? And one possibility is to inhibit proliferation of tumor cells by suppressing cyclin kinases. And there's a compound that's called palbociclib that inhibits cyclin kinase CDK4 and CDK6. And we inspect a randomized control trial of palbociclib in women with advanced breast cancer. Now the patients are these were all estrogen receptor positive patients, so they're treated with an anti-estrogen compound, and fulvestrant not only blocks function of the receptor but also results in its downregulation, so that this is a very effective anti-estrogen treatment. And the reason this treatment is necessary is because proliferation of tumor cells runs over the estrogen receptor. So what we see here is palbociclib resulted in an improved overall survival of these women with advanced breast cancer, as shown here. This is a 4-year observation of this particular treatment, and it seems that if we look at different characteristics, age, race, ethnic group, spread of tumor, etc., the women seem to, in general, to profit from the administration of this treatment. And here it is in a little more detail. Overall survival with palbociclib was improved, particularly if the women showed sensitivity to estrogen inhibition, as shown here. And if they did not, then the results were no longer statistically significant. If we look at a percentage of patients that followed over this 48-month period, we can speculate that total survival in these women was increased by about 9 months, and that seemed to be independent of whatever else these women were then, whatever else treatments that they received. Increased survival of women with advanced breast cancer, it amounts to about 7 months, but it's statistically significant. And if we look at progression-free survival, this is also significantly improved by means of this cyclin kinase CDK4 and 6 inhibitor. The review in the New England Journal concerns lymphedema after breast cancer treatment. And if lymph nodes are removed in the axilla, the development of lymphedema is extremely common. And this is a major complication in women after breast cancer. And the review concerns with treatments that are given to these women. And these treatments are not terribly successful, I'm afraid. Here's some examples shown here. You can see the marked swelling of the left arm in this woman, and even more marked swelling of left arm in this woman, and swelling of the right arm in this woman. This is called a peau d'orange, appearance of the skin. And there are a variety of treatments to try to combat this lymphedema, raising the extremities and massage treatments and various things. And these are not very encouraging, I'm afraid. And also there are strategies for risk reduction, including only biopsying the sentinel node and leaving the other nodes alone. If the sentinel node is negative, to try to reduce the occurrence of this syndrome. And also mentioned in this article is the necessity of separating this lymphedema from lipedema, which is another condition that can look sort of similar, which is invariably bilateral, not always associated with obesity, and how this is clinically done is also a topic in this review. Here's a picture in the New England Journal. This is a 70-year-old woman who develops shortness of breath. Actually, she has stridor. And a CT shows here a mass inside a bronchus. And we learned that 3 years prior to this condition, this woman was presented with malignant melanoma. And it was on her left shoulder, it was removed. Lymph nodes at the time of the removal were negative, but what we can see here with this starkly black tumor in this bronchus, this is a metastasis from the melanoma. The New England Journal also announces a new series of case studies in social medicine, trying to make the point that a lot of social disasters have medical implications, and how we interpret these social disasters has a bearing on how these patients are treated. And there's an announcement that this series is coming and what it will entail. And the first example, I'm going to show you this, is a case description. It concerns the problem of medicalization and demedicalization. What we see here is a homeless person, and in the United States, about half the homeless people actually have some sort of a psychiatric illness. Schizophrenia in these patients is common, and this is a vignette concerning a homeless person who is obviously schizophrenic, who is treated with antipsychotic medications, but he doesn't follow up and he doesn't come to clinic because he's also alcoholic and takes drugs and these various things. And a psychiatry resident is confronted with this patient in an emergency room, and she decides to prescribe an antipsychotic drug, olanzapine, I'm not familiar with it, and doesn't want to admit him to the hospital because she has certain perceptions about homeless people. Why don't they get a job, and why don't they come to clinic, and these various things. And her attending points out that in earlier times we had state hospitals where psychotic patients were cared for. The care wasn't always ideal, but at least these patients weren't thrown onto the street, as is the case today. And so her attending physician recommends that this patient be admitted to the hospital, but several hours pass and there's a change in shifts, and the next attending agrees with the resident that this patient shouldn't be admitted to the hospital because this psychiatric illness has been demedicalized, is the term that's used here, and the patient is returned to the street. And that's the discussion of what happens here. But it turns out that this patient doesn't return to clinic and has no follow-up appointments because he ends up going to jail for some sort of relatively minor crime, felony, and at least in jail he'll no longer be on the street and is by definition no longer homeless. Okay. So here's the patient of the week in the New England Journal, and it involves a 68-year-old woman, and it's a breast cancer patient, a patient that develops breast cancer in one breast, and then years later develops cancer in the other breast, and is then evaluated to see if she has a BRCA mutation, which she does not, and it concerns how she's cared for. And she then comes in with pleuritic chest pain and pain in the axilla. Pulmonary embolus is initially suspected, and indeed she has evidence of pulmonary embolism. And the reason for that is that she probably has metastases. And then the question is, how is the tumor progressing, and what can be done about this state of affairs? This is a bone scan, scintigraphy, and what we see here is multiple rib metastases and shoulder metastases, etc., indicating metastatic advanced breast cancer. So then finally a biopsy is done showing metastatic breast cancer, and additional treatments are then conducted, and you might have already guessed she receives the CDK4/6 inhibitor, palbociclib, and she also receives an aromatase inhibitor to try to block estrogen receptor signaling, and this results in a transient improvement, but then the tumor recurs. So we reviewed this 2 weeks ago. A liquid biopsy is performed, and blood is obtained and then sequenced for circulating tumor DNA. And indeed, this circulating tumor DNA indicates that she has an estrogen receptor mutation, which probably plays a role in her resistance to this treatment. And all of this advanced breast cancer therapy is discussed here, and then she's finally treated with capecitabine, which is a prodrug for 5-fluorouracil. It's not clear to me why the patient isn't just treated with 5-FU instead of this prodrug, but that's currently how this condition is treated. And so this is the case discussion involves how to treat advanced metastatic breast cancer. Now we'll turn to the Lancet, and the first topic in the Lancet has to do with vaginosis. And the vagina also features a microbiome. And if this microbiome is perturbed, first of all, this leads to some symptoms, not necessarily inflammatory kinds of symptoms, and that's why it's called vaginosis rather than vaginitis. But if we make a smear of vaginal secretions in women with this condition, we see that the favorable, good lactobacilli have disappeared, and this can be scaled in a so-called Nugent score, and I've outlined that here. And the idea here is that a bad Nugent score, the presence of vaginosis, could possibly lead to preterm premature delivery. And so to avoid this problem, pregnant women with vaginosis are treated with antibiotics. And this is a randomized trial of this hypothesis to see if preterm delivery and pregnant women with vaginosis can be somehow inhibited by the administration of clindamycin. So women that had a bad Nugent score and that were pregnant were randomized to clindamycin or placebo, and otherwise all their other clinical characteristics were similar, as shown here. And you can go over this table in detail if you want, but basically, and unfortunately there are only tables in this particular article, clindamycin did not inhibit preterm delivery, premature delivery, in these pregnant women with vaginosis. So this is a negative study. So this treatment probably does not result in any benefit for these women. Now, the next topic is the treatment of type 2 diabetes, and there are some very novel, quite impressive treatments that are now available, and we've discussed agonists of glucagon-like peptide, GLP-1, which results in insulin secretion and blocks glucagon secretion and has all sorts of favorable effects on various organ systems. This drug has to be administered by injection, but modern recent preparations require only one injection per week. Another target that is called the glucose-dependent insulin-tropic peptide, GIP, and this is also a wonderful target. This is another gastrointestinal hormone that's good for beta cells and also results in insulin secretion and bone marrow formation and all sorts of wonderful things. And Eli Lilly has developed a drug that not only is an agonist for GLP-1, but is also an agonist for GIP. And this drug, as abbreviated here, was compared to a GLP-1 receptor agonist or to placebo in a fairly large randomized controlled trial. And this is pretty impressive. The first thing we can look at is hemoglobin A1C. Now with placebo, this didn't fall. With the GLP-1 agonist alone, it falls, but with the GLP-1 GIP agonist, it falls even further. And what's also impressive is here again is hemoglobin A1C decreases in a dose-dependent fashion more effectively by 2.5%. That's not bad. And so invariably the patients had a hemoglobin A1C of less than 7%, but some of them decreased as low as 5 points, almost to 5% with this GLP-1 agonist plus GIP agonist as shown here. What's also impressive is weight loss in these patients, and I think this is very impressive. The treatments that we have for type 2 diabetes usually result in weight gain. Well, the people that received the highest dose of this Lilly compound lost 10 kilograms. That's pretty good. So these are impressive results. And this drug had to be only injected one time per week in these patients. The third paper in the New England in the Lancet had to do with complications related to arthroscopic meniscus surgery in the UK, and this is a large observational study of 700,000 operations. And what we learn here is that the complications were not very common, but the ones that were most severe involved infection or the development of pulmonary embolism, as we might have suspected. The occurrence of these complications was more common in people who were above 80 years old or people that had morbidity from other medical conditions. So, tabular information on the same topic. So, meniscus surgery in older people has a risk, and the usual candidates are pulmonary embolism and infection. Then, here's another result from the Global Burden of Disease study, and this has to do with mortality due to low-quality health systems. This is a review of poor countries or middle-income countries, that's all poorer than the United States and Western Europe, how well do they do against common diseases, infectious diseases, and also non-communicable diseases, and how much of the poor outcome that they exhibit is related to poor quality care, even if care is present. And the review also concerned non-communicable diseases, cardiovascular disease, gastrointestinal disease, diabetes, and cancer. And here are the countries that are involved. Russian Federation, India, almost all of Africa with the exception of Saudi Arabia and Israel, and almost all of South America with the exception of Chile and Uruguay as shown here. And what we see here is in terms of cardiovascular disease and deaths related to that, poor quality care plays a substantial role in addition to people that just didn't bother showing up at all. And the same kinds of patterns are seen for neonatal death, tuberculosis, even road injuries, trauma-related conditions, etc. So even if care is available, if it's of poor quality, as we might imagine, the outcomes are unfavorable. Now, the reviews in the Lancet, again, concern opportunities in global health, and this is called implementation research, which means that we know how to do it, we just have to turn it over, and that's what this review is all about, and the key messages are here. How to turn it over, how to have enough money to turn it over, and how to get indolent systems to deal with these problems. And if you're interested in this kind of changes, want to make changes in policy, etc., you can look at this review and the lengthy conclusions that go along with it. Then also, the second review in the Lancet concerns the idea of universal health coverage, and you'll remember that there was a big conference in Alma-Ata where the attendees decided that all individuals on the planet should have universal health coverage and provided for them by their governments. And the discussion here has to do with is this a good idea or is it a white elephant? And in the English language, white elephant, as I learned from Google, white elephant is a possession which its owner cannot dispose of and whose cost, particularly that of maintenance, is out of proportional to its usefulness. And if we look at this introduction, it's a discussion of what people in Ghana think about priorities. And it starts out with, "Doctor, come quickly, you have to do something. That old woman is a witch." And if we read this discussion, we learn that the perceptions of patients that live in villages in Ghana is really quite similar to perceptions that existed in Europe 400 years ago during the time of the 30 Years' War, which you can read about in Daniel Kehlmann's book here, describing Till Eulenspiegel and people in the 30 Years' War, where 400 years ago people in Europe believed pretty much what the people that live in a Ghanaian village do today. And that's the discussion that concerns here. And if we look at that, one of the problems is governance and financing institutions. Ghana used to be a British colony, but then the British left. Then it turned into a military dictatorship, and then it turned into another form of dictatorship. And of course, this also, this extractive kind of government also has an impact on the quality of care that's provided. And that's the discussion in this review. And it's what we see here is approaches to healthcare in Ghana involve horizontal approaches that would be to provide outpatient care and some sort of clinics that the patients can go to. But their belief system doesn't favor the administration of care of this nature. Then there are vertical interventions that are done. Group comes in from Bill and Melinda Gates and treats malaria or eradicates elephantiasis or this sort of thing. So this is a balance between horizontal and vertical kinds of approaches to healthcare. But then what we see is that the poor Ghanaians, total poverty between 1962 and 2000, then the financial conditions in Ghana seem to be impressively improving up to 2014. Now this falls off again, but then it might be related to the fact that, similar to the United States, perhaps only 1% of the population benefits from this improved economic association, and 99% of the patients of the population does not. So that's the discussion here, and you can, so it questions this naive idea of providing universal health care to the world's population at large, which now amounts to 7.5 billion people. To return to clinical medicine, I found this paper in the British Medical Journal. This is from Denmark, and it concerns diclofenac, which is a common non-steroidal anti-inflammatory drug given for whatever ails people. And this is an evaluation of diclofenac compared to other non-steroidal anti-inflammatory drugs or paracetamol in the treatment of pain, and what this does to cardiovascular risk. In Denmark, all prescriptions are monitored in a statewide system that involves the entire population, so they were able to follow every person in Denmark that swallows diclofenac or other non-steroidal anti-inflammatory drugs. And if we look at, and this is an association study, the appearance of atrial fibrillation, ischemic stroke, heart failure, myocardial infarction, cardiac death, or any sort of cardiovascular event was substantially higher in people taking diclofenac compared to paracetamol or ibuprofen or naproxen. And this is an indictment of diclofenac in terms of an increase in cardiovascular risk. And this also applied to men and women, irrespective of age. And you can look at this paper. But the implication here is that diclofenac, which doesn't require a prescription in Denmark or in Germany either, for that matter, increasing cardiovascular risk compared to other options that could be administered. There was also a paper in JMA, which includes the guidelines for physical activity in the United States based on METs per week. And so a MET is a metabolic equivalent task unit, and if you're sleeping, you're only generating 0.9 METs. If you're awake, watching television is 1.0 METs. Bicycling at 50 watts, very light effort, 3 METs. Even sexual activity is monitored here in terms of METs, but you can't do that 150 minutes per week. Or maybe you can, then that might be an option. Serious jogging or rope jumping, at any rate, those are the METs. And basically, the guidelines call for 150 METs per week, and that's not very much. So you can pick your activity based on these guidelines, and then exercise is good for you, and it reduces cancer risk, and cognitive function is better, and your chances of getting Alzheimer's, it's just good for everything. So better go out and get some exercise. Improves health and avoids frailty, etc. So that was shown here. We're going to close with this patient out of the Lancet, and it concerns a 62-year-old alcoholic man that comes into the hospital with a serum sodium of 130. The authors claimed that over the course of 4 days, they only increased his serum sodium to 140, but he got this anyway. And this is central pontine myelinolysis, and this is a rather crucial area where a lot of things go through here, including the reticular activating formation that determines whether or not you're awake. And this poor person has central pontine demyelinization, had to go to a nursing home and eventually died. This condition is associated with hyponatremia. That's why the guidelines suggest only a very gradual increase in serum sodium, although it can occur spontaneously, particularly in patients that are alcoholic, and exactly why this patient developed this complication. This is how this looks if you do an autopsy section, and the pathophysiology of this condition might possibly involve the sodium pump and changes in osmolality and cell swelling, etc. And this kind of regulation is discussed. But you should at least be aware of central pontine myelinolysis, and that it's associated with alcoholism and hyponatremia. That's it for this week. Join me again next week, or stick around and you can hear the same story in German. And that will take place in 20 minutes from now. Thank you very much.